Our next speaker is Dr. Mark Bilski, who will be speaking about radiosurgery for spinal metastasis.
Thank you very much. Thanks so much. Thank you very much to the organizers for allowing me to present this. Here are my disclosures, which are not relevant. 20% of cancer patients will develop spine metastases over the course of their illness. We've seen an increased number of metastatic spine tumors as MR and PET imaging have improved detection and newer systemic treatments have improved survival, but are more effective for visceral than for bone disease. The goals of treatment for metastatic disease are palliative. We want to improve or maintain neurologic function, achieve local tumor control, mechanical stability, pain relief, and ultimately improve quality of life. Far and away, the single greatest advance in the treatment of metastatic spine disease is stereotactic radiosurgery. It's defined as high-dose per fraction conformal radiation, typically in the spine given as 18 to 24 gray single fraction, or 8 to 10 gray times 3 fractions. Compared to conventional external beam radiation, which is often defined as 3 gray times 10 fractions, stereotactic radiosurgery has a shorter treatment time and an earlier return to systemic therapy, but the great advance is the ability to give a cytotoxic tumoral dose that is ablative, and this has fundamentally changed our treatment paradigms, including the indications for and type of surgery that we do. There have been major advances in radiosurgery over the past decade, including technology, determining optimal tumoricidal doses and dose constraints for organs at risk, and even defining the radiobiology of radiosurgery. The technological advances include non-invasive immobilization and isocenter verification using cone beam CT, but the great advance is the development of conformal photon beam delivery systems, all of which can give very high doses to the tumor within millimeters of the spinal cord. This patient population with metastatic disease is incredibly complicated. A decision framework has been determined that integrates 4 sentinel decision points: neurologic, oncologic, mechanical stability, and systemic disease to decide best treatment. The neurologic and oncologic considerations are made in combination. From a neurologic perspective, we're concerned about myelopathy and functional radiculopathy, but principally about the degree of spinal cord compression. An MR-based epidural spinal cord compression scoring system has been validated to facilitate decision-making and reporting. From an oncologic perspective, we're concerned principally about radiosensitivity as it relates to local tumor control. Radiosensitivity has been completely redefined as we've transitioned from conventional external beam radiation to stereotactic radiosurgery, and that will be the focus of this talk. For completion's sake, in the NOMS framework, mechanical instability is a separate assessment, as no amount of radiation will stabilize an unstable spine. The SINS criteria has been developed to define instability in the neoplastic setting, and once determined, patients are often candidates for percutaneous cement augmentation, pedicle screws, or open surgery. And finally, systemic disease and medical comorbidities significantly impact our ability to treat. Expected survival is a major determinant in treatment, and with the newer biologics and checkpoint inhibitors, we've extended survivals for all cancers. Here for melanoma, looking at nivolumab, a PD-1 inhibitor, compared to standard chemotherapy, and this needs to be considered in decision-making as well. Again, from the oncologic standpoint, what we're really concerned about is the radiosensitivity. To conventional external beam radiation, there's very little in the literature, but what's there is remarkably consistent. There are radiosensitive tumors, such as the hematologic malignancies, breast and prostate cancer, versus the radioresistant tumors, which are really the remainder of the solid tumors. For the radiosensitive tumors, we have 2-year local control rates of 86%, versus the radioresistant tumors, 2-year local control rates of only 30%. Stereotactic radiosurgery overcomes this radioresistance, and all tumors become radiosensitive. In a recent series, 2-year local control rates were demonstrated at 98%, and these are histology-independent responses. And this has fundamentally changed the way we see these tumors in terms of their responses. Here's a patient with multiple myeloma, a very radiosensitive tumor, got conventional external beam radiation, and you can see that the tumor completely apoptosed, decompressing the spinal cord, and recovering the patient to normal neurologic function. The problem is you never see these responses with the radioresistant tumors. So while there's still a role for conventional radiation for radiosensitive tumors, most centers are now going to for radioresistant tumors with minimal or no spinal cord compression are going to stereotactic radiosurgery. Here's a multi-institutional review of 387 cases looking at multiple tumor histologies. The median dose was 8 gray times 3 fractions, excellent local tumor control at 2 years of 84%, but declined at 4 years to 62%. We think that dose matters in terms of the response and the durability of the response. Here's a series from Memorial Sloan Kettering of 811 tumors, 82% of which were radioresistant. Contours were according to the Radiosurgery Consortium guidelines. The prescription dose was 18 to 26 gray single fraction, but absolute dose was analyzed as a continuous variable, and an optimal cut point was set to establish a low versus high dose group. The median dose of the planning target volume in the low-dose group was 16.4 gray versus the high-dose group 22.4 gray. The only significant factor in the incidence of local failure was the dose of radiation. In the low-dose group at a year, there was a 5% failure rate versus the high-dose group 0.4%. And at 48 months, at 4 years, the low-dose group increased to a 20% failure rate versus only 2.1% in the high-dose group. What's most remarkable is that these responses are both histology and volume independent. So we overcome radioresistance with high-dose per fraction radiation. Part of the reason for that is we create more double-stranded DNA breaks with radiosurgery than conventional radiation, and that's a lethal event in radiation. But there are also unique mechanisms in radiosurgery, including endothelial and immunogenic effects, which we can potentially take advantage of. The endothelial effects are mediated through the acetylsphingomyelinase pathway, which creates ceramide, microvascular dysfunction, and hypoperfusion. And it's this hypoperfusion that does not allow sublethal DNA damage to repair and overcome stem cell resistance. VEGF is an inhibitor of the acetylsphingomyelinase pathway, and now there's experimental evidence that VEGF inhibitors can act as radiosensitizers. As for the immunogenic response, radiosurgery increases tumor antigen presentation, which promotes a T-cell-mediated cytotoxicity. In combination with checkpoint inhibitors, we see an enhanced cytotoxic T-cell response, which improves our local tumor control, but also creates this very interesting abscopal effect where local radiation now impacts the systemic response. Here's a patient with melanoma who was chronically on ipilimumab and had stable chest disease. She was irradiated 24 gray single fraction to a paraspinal lesion, and her chest disease resolved. The abscopal effect now means that local radiation becomes part of systemic treatment. While we need to give a cytotoxic dose to the tumor, we need to protect organs at risk. Using inverse treatment plan, we can set very tight dose constraints to minimize toxicity. One strategy to give an ablative dose to the tumor while maintaining within the constraints of normal tissue tolerance is organ displacement, where saline is put into the retroperitoneum to displace the kidney and bowel to make a better target for the radiation. Obviously, the one organ we can't displace is the spinal cord, but at a very tight maximum dose of 14 gray, we have less than 1% chance of creating myelitis. This tight dose constraint on the spinal cord is a reason we can't use radiosurgery for high-grade cord compression in the setting of radioresistant tumors, and that's predicated on the fact that in multiple series, all local failures receive less than 15 gray to some percentage of the planning target volume. If our cord dose is less than 14 gray with a 10% per millimeter fall-off, then either we give a cytotoxic tumoral dose that overdoses the spinal cord, or we underdose at the margin of the cord where we need the greatest control. Secondly, the resolution of soft tissue disease can take months, unlike the multiple myeloma that I showed you earlier. So we get no immediate effective decompression of the epidural disease. And finally, SAMRU tried stereotactic radiosurgery for high-grade cord compression, and 20% of the radioresistant tumors demonstrated neurologic progression. And it's for that reason that for patients with high-grade cord compression with radioresistant tumor, we consider upfront surgery. This is largely based on the Patchell study. It was from Lancet 2005. It was a prospective randomized trial of solid tumors looking at high-grade cord compression comparing surgery to conventional external beam, and surgery was better in every outcome variable. And based on this and a number of other studies, the Spine Oncology Study Group made a strong recommendation that patients with high-grade cord compression due to solid tumor malignancy undergo surgical decompression and stabilization followed by radiation therapy. And the question became, what kind of surgery and what kind of radiation? With the integration of radiosurgery, the surgical goals of spinal cord decompression for neurologic salvage and mechanical stability using screw rod systems remains the same. But the oncologic goal of how we achieve local tumor control is completely predicated on the radiation response. So when we use conventional external beam radiation, we had no faith that it could control tumor in the postoperative setting. So we often did maximally cytoreductive surgery, either gross total resection or en bloc. And that was very poorly tolerated in this patient population. With the integration of radiosurgery, the oncologic goal becomes simply to reconstitute the thecal sac to create a target for radiation. And this has led to the concept of separation surgery. Here's an 86-year-old with papillary thyroid cancer, age C, with very high-grade cord compression and 3-level vertebral body disease. And I would submit to you that there is no way to get this patient through a 3-level front-back surgery. We took this patient to a very simple separation surgery, a posterior lateral decompression simply to reconstitute the thecal sac. We left residual vertebral body tumor behind, long posterior fusion. This patient got 8 grade times 3 fractions, fully ambulatory 2 years out with well-controlled disease. There's very little in the literature that looks at conventional external beam radiation as a postoperative adjuvant. Here's a series from Clay Camp SAMI of 101 patients. 43% underwent complete resection. Adjuvant treatment was conventional external beam radiation in all patients, and despite this aggressive surgery, local control was only 30% of the year, so 70% of patients recurred at a year, and the biggest predictor of recurrence was tumor histology. Here's our series of 186 patients that underwent this very simple separation surgery followed by radiosurgery. Most patients were operated for high-grade cord compression with radioresistant tumor histologies, and 50% had failed prior radiation. There were 3-dose strategies: high-dose single fraction, high-dose hypofractionated, and low-dose hypofractionated. The 1-year cumulative incidence of recurrence was 16%, but if we gave a high enough dose single fraction or high-dose hypofractionated, we had less than 10% recurrence at a year, and there was no association with radioresistant tumor histology or prior radiation. The criticism we've received about separation surgery is that if we don't formally reconstruct the anterior column, the patients will fall apart. Here's a series of 318 patients that underwent separation surgery, and the fixation failure rate was only 2.8%. In this patient population, it's a remarkably effective strategy. Theoretically, one of the advantages of radiosurgery is that it should decrease wound complication because the beams are brought in from so many different trajectories. Here's a series of 165 patients that underwent preoperative radiation. If we use conventional external beam radiation, we had a 17% risk of wound complication versus radiosurgery, only a 6% wound complication rate. Reducing wound complications will significantly reduce the morbidity of local rotation flaps that are required for wound salvage. Stereotactic radiosurgery has truly become the focal point of treatment for metastatic disease. There's still a role for conventional external beam radiation for radiosensitive tumors, but for radioresistant tumors with minimal or no spinal cord compression, most centers are going to radiosurgery. And for radioresistant tumors with high-grade cord compression, this very simple separation surgery with radiosurgery to get local tumor control. If the patient's unstable, it's a separate assessment. They need to be stabilized, and everything is predicated on what the patient can tolerate from a systemic disease standpoint. There are a number of future directions. We need to standardize dose reporting for the literature. We have contouring guidelines for the upfront setting, but need to establish those for the postoperative setting as well. Tumor responses are based on the Spino criteria, which look at standard MR imaging, but there's always radiographic residual in the bone, and it's unclear whether there's viable tumor there or treated. Now using DCE MR, particularly looking at plasma volume, we have very reliable indicators of whether there's a residual or recurrent tumor long before standard MR imaging changes. Separation surgery is beginning to integrate MIS techniques as pioneered by Peter Gersten, Dean Chow, and my partner Ilya Laufer. P32 intraoperative dural plaques are being used to clear dural margins to make a better target for the radiosurgery, especially for patients with circumferential epidural disease. And now spine laser ablation is being used as a percutaneous measure again to decompress the spinal cord to make a better target for the radiation, and we await long-term outcome data on these patients. And finally, for primary tumors such as chordoma, they've been found to be remarkably radiosensitive, and we're looking at ways to integrate this as adjuvant, neoadjuvant, or potentially even definitive therapy. There have been a number of neurosurgeons, along with our radiation oncology colleagues, who have made major contributions to making radiosurgery the revolutionary and truly very meaningful advance in the treatment of metastatic spine disease. Thank you very much.